Hello, everyone. Yeah, it's a rare treat to have two movement specialists today. I'm really thrilled that Dr. Ospina is joining us today. And we're going to do the same format as last time. It's going to be informal. It's more of a discussion. It's not a formal lecture, so to speak. And if there's something that piques your interest on the topic that we're discussing, please raise your hand or go to the microphone and please interact with us if you could, because this will be an interactive session. Okay, so we're going to talk about different topics in managing Parkinson's, mostly controversial things that we do differently. Movement disorders or the field of medicine or neurology. I mean, there's so much art when we practice medicine. So sometimes I do things differently from Dr. Ospina, and we're going to discuss how we manage Parkinson's and why we think patients should be doing this versus that. Okay, so one of the most controversial things that we talk about and we think about, Christina, is the use of. Can we advance this?
Yeah, technology.
Is how to manage early Parkinson's disease. So back when I was back when I was a fellow not too long ago, and Dr. Ospina and I were trainees just around the same time. Back then, there was a very strong push for levodopa sparing strategies. What that means is we try to delay the use of levodopa, but that has changed with time. So, and one of the things that we had back then, it was a relatively new, was an MAOB inhibitor called rasagiline. Although before that there was selegiline. So the question is, should we be using this so-called MAOB inhibitors as levodopa sparing strategies in the beginning versus, forget about the MAOB inhibitors, let's just do levodopa from the get-go. It's the best medicine. It's a direct replacement for dopamine. Why even bother with the so-called weaker medicine? So I'd like to pick your brains on what your thoughts are on that.
Right, so that's true. So 20 years ago, we thought, yes, we should be levodopa sparing. We don't want to make our patients dyskinetic 5-6 years into the disease. And let's start MAOB inhibitors, especially with rasagiline, because we had the Adagio study that showed that maybe patients who started on an MAOB inhibitor like rasagiline, we could slow down the disease progression in those patients. But that didn't pan out. That wasn't true. We did a next study, Largo study, and it didn't show that patients who were on rasagiline had a delayed, that had their disease was modified or slowed down in any way. And now we know that there's no reason to have levodopa sparing. If we're looking at the room today, there's literally not one single person here with dyskinesia. Whereas if we were to have this 20 years ago, 90% of the room would be dyskinetic. They'd kind of be wiggling out of their chair. And there was another study that was done. It was actually an Italian study. So they compared a cohort of patients in Italy where they have access to levodopa to a cohort of patients in Ghana where there is no levodopa. They basically have macuna beans and nothing else. And so what that study showed is that when you gave patients levodopa, especially the Ghana patients, years 6, 7, and 8, that they developed dyskinesia right away. So the dyskinesia is a factor of the disease progression, not of using levodopa. So the reason that you start levodopa 1 tablet 3 times a day initially, and you can have a turkey sandwich, and you could be 30 minutes late with your dose of levodopa for lunch, and you don't notice any wearing off, is that initially you have a very wide therapeutic window when you start the disease. By the time you come into the neurologist office and you're diagnosed with Parkinson's disease, 60% of those cells that have dopamine have already died off. But that means that you still have 40% of those cells still living and producing dopamine and acting as a buffer for immediate release levodopa, that we can talk about different formulations later on, which only has a 90-minute half-life. So you don't notice that I took my medicine, it only lasted 90 minutes, I even had a turkey sandwich, nothing happened, because you have that very wide therapeutic window, that buffering capacity. But as the disease progresses and you continue to lose those dopamine-producing cells, more and more of the dopamine is coming from your medication. And then it is very critical what the half-life of that medication is. Is it immediate release or a longer acting form of levodopa? And that's why you notice the wearing off. It's the pharmacokinetics of the medication, not that levodopa is toxic in any way, or that you habituate to the medicine, or you develop a tolerance to the medicine like you would to the opiates, pain medicines. So there's no reason to be levodopa sparing in 2024, especially when we have long-acting levodopa like Rytary, and we're going to get IPX203 hopefully in August, a longer acting form of levodopa. So our job is to try to maximize your well-being and your on time throughout the 24-hour period so that you can do things like Rock City boxing and exercise and those sorts of things. And there's no reason to start Resagilene today. Today I start all of my patients on Rytary if I can get away with it from the insurance point of view. And when IPX203 comes out, that's going to be my first line treatment, and then I'll use these other medicines.
Yeah. But is there a subset of patients, though, that you would even consider Resagilene in the beginning or as an adjunct therapy? In other words, add on to levodopa down the road?
Yeah, so Resagilene is approved both for monotherapy, so as first line, you're not on anything else, and as an adjunct to patients who are already on levodopa. So how does levodopa work? So, the reason that we have to give you levodopa, not dopamine, is that dopamine doesn't cross the blood-brain barrier. So we have to give it as a prodrug, levodopa. And then that levodopa is actually chewed up by two enzymes in the periphery and one up in the brain. So one is dopa decarboxylase. That's the reason why carbidopa is in all of your formulations of Sinemet or immediate release or Rytary. So that prevents levodopa turning into dopamine in the gut or in the periphery, causing lots of nausea, vomiting, low blood pressure. And that's actually how Sinemet got its name, synemesis, without vomiting, back in the 70s when drug names actually made sense. And so you have carbidopa, and then there's another enzyme that chews up your levodopa in the periphery called COMT. And that's why we use medicines like entacapone or Comtan or opicapone or Ongentys. So basically what you want to do is block both enzymes. You start levodopa, you block both enzymes because you don't want to leave any levodopa on the table. Push as much levodopa from the gut into the brain. So right now, does anybody know of that yellow Sinemet tablet that you guys are taking every 3 hours? How much of that levodopa is actually turning into dopamine in the brain? It's almost nothing. It's less than 5%. So we have to use all of these other adjuncts like Ongentys to increase the dopamine that makes it to the brain. And once the dopamine makes it to the brain, and the dopamine that you're still making, that's actually metabolized by an MAOB. And so that's when we use selegiline, Resagilene, or safinamide to block that enzyme and make it last longer. So from a pharmacokinetics and a chemistry point of view, you would use levodopa, you would block dopa decarboxylase, so carbidopa, which they all have. You would block COMT with an entacapone or a opicapone, get it up to the brain, and then you would add an MAOB inhibitor like Resagilene.
Yeah. So in the early stages of Parkinson's, like you just diagnose a patient with PD, and patient has mild symptoms, probably maybe a little bit of a tremor, maybe a little bit of slowness. At that point, would you start levodopa, or would you even consider a weaker drug like Resagilene?
So it depends on the patient.
Or selegiline. Yeah.
So it depends on the patient. Let's say my patient is young onset. So right now, we're seeing more young onset PD.
Right.
That seems the fastest growing cohort in Parkinson's disease. So if I have a 50-year-old who's still working, who has to be on all day long, then I'm going to start a levodopa. If I have an 80-year-old patient who has a very mild tremor, no gait or balance issues, no swallowing issues, is just sort of a mild rigidity bradykinesia, then I could consider using Resagilene in that patient.
And do you have any feel as to which of these MAOB inhibitors, so far we have 3 in the market, right? So selegiline came out first, then Resagilene second, and then more recently is safinamide. So do you have a feel as to which one of those 3 is most potent, so to speak? Either in early or more advanced Parkinson's.
So most probably safinamide, but of course it's expensive.
Yeah.
Although Resagilene,
it's a once-a-day drug.
It's a once-a-day drug. And we want to use once-a-day drugs. In Parkinson's disease, remember, you guys have bradykinesia, or slowness of movement. That translates into all of the muscles of the body, including the muscles of the gut. And then in the gut, it's called gastroparesis. It's a slowed gut. And because the gut is slow, more fluid gets sucked out of the stool gets hard, and you get constipated. And once you're constipated, that gastrocolic reflex doesn't work. So when you swallow something, it should transition into the small intestine right away in less than 30 minutes. But if you swallow something and the tummy says, hey, I'm digesting this turkey sandwich, and your colon sends back a message, yeah, I haven't had a bowel movement in 3 days, everything kind of stops there. So if you take a tablet and it sits in your stomach for 2 hours, that's called delayed on. It might as well be on your kitchen counter, it's not doing anything. So we want to use once-a-day medicines in PD because we only have to transition that pill once a day versus 3 times a day. So that's why we would use once-a-day medicines. Although Resagilene, again, also once a day, is generic, although the generic price is not very generic.
Right. Which is true for a lot of generic drugs nowadays,
exactly.
Right? Mm-hmm. And then, are you still getting phone calls from pharmacies about you having to sign off on the interaction between MAOB inhibitors and the so-called antidepressants? I still get this, faxes regularly.
Yeah,
but can you enlighten us on this so-called serotonin syndrome and the interactions between MAOB inhibitors and?
Right. So although it's still on the pharmacist's computer saying that, oh, you shouldn't be taking antidepressants, like Lexapro or Celexa, and be on MAOB inhibitors like Resagilene, that's actually been taken out of the PI. And in fact, most of the patients in the clinical trial for Resagilene were on antidepressants. So there's no need to modify your diet. You can still have, stinky cheese and red wine, and herring and all of those things. And you can take your antidepressants, no problem. And so, but we still do get it flags on the pharmacist's computer, and so we still have to click that in our EMR. And probably they kind of stop you at the pharmacy.
And then you mentioned Rytary. I love Rytary as well, but given the cost, is there like a population of patients where you would say, wow, I really want to use Rytary despite the cost because of one? Is there a set of patients that you would really want Rytary to be used for?
Yes, especially my young onset patients who are still working. So if we have a lot of those chip factories here, a lot of engineers are getting Parkinson's disease. They go in and out of these clean rooms and are working on these things. And so you can't, wear off. And remember, when you wear off, it's not only your body where you have trouble with fine motor coordination and putting on the little bunny suit and using a keyboard and mouse, but your brain also turns off. So you have bradykhrenia, slowness of thinking, and that can't happen right in the middle of your workday. Or if you need fine motor coordination because you're a veterinarian and you have to clean little cat teeth, you need to be on all day. Sure. And so for those patients, we definitely have to fight to be on long-acting levodopa, which hopefully we'll get IPX203 later on this year.
And just for our audience knowledge and information, what's the difference between Rytary and Sinemet, the brand name Sinemet? What's the difference? They're both brand names.
Yeah, exactly. So Sinemet, remember the Sin-emesis without vomiting. But remember, Sinemet is a drug that came out with the moon landing. And so why in 2024 are we still using drugs that came out with the moon landing? So Sinemet is a tablet, and it has 25 milligrams of carbidopa and 100 milligrams of levodopa. But it has a 90-minute half-life. So if you're newly diagnosed and you're in that honeymoon period, for the first 5 years, Sinemet works great because you can be late with it, you can have lots of protein and you can be constipated and nothing happens. But once you're out of that honeymoon period and all of or most of your dopamine is coming from the pill, then you really do notice when the pill wears off, the pharmacokinetics of the pill. So Rytary is a capsule, and it has both immediate release and extended release beads of carbidopa, levodopa. So it absorbs over time. So it goes into the small intestine, and it kind of coats the jejunum, the small intestine, and releases over 4 years. Same thing, the same sort of pharmacokinetics will be part of IPX203, only it'll be a longer acting sort of 6-hour version of levodopa, so that it releases over time, and once it gets into the small intestine, it hangs out there for several hours, and so it's always first in line to get into the little transporter, the little elevator that competes with the protein in your food. And so that way your drug is always first in line to make it from the gut into the brain.
Yeah. I also use Rytary for patients that are very sensitive to the regular carbidopa, levodopa, simply because the milligram per milligram, like for instance, if I use the 95 milligram of Rytary, which is 95 milligrams of levodopa, the effect is not the same as 100 milligrams of the generic carbidopa, levodopa. My conversion is usually 1:3. So if I use Rytary, patients are able to tolerate it better. It's like, for instance, patients who get very sleepy with immediate release carbidopa, levodopa, patients who get very nauseous, especially at the peak of the medication. This is where Rytary comes in. So patients are very sensitive to the immediate release or the carbidopa, levodopa. Rytary seems to be a little friendlier in terms of side effects. But is there any advantage of combining immediate release and sustained release carbidopa and levodopa from the get-go? They're not yet fluctuating. They don't have the ons and offs yet. The question is there any advantage of combining immediate plus sustained release in the get-go? From the get-go.
So I don't do it from the get-go, but I definitely have patients who were on immediate release carbidopa, levodopa. So they're used to that big kick, so it has an initial big peak, whereas Rytary, the peak is not as high, and then it kind of tapers down over a longer period of time. So those patients who've been on it for a long time and they miss the peak, they many times will take a dose of yellow cinnamon or a half or a quarter, and then their Rytary because they missed the peak. So I definitely have those patients who mix and match. Or I definitely have patients who use on-demand therapy like Ambrosia, an inhaled form of levodopa that bypasses the gut to get on quickly, especially in the morning. So they have a morning off or they have a delayed on because they ate a lot of protein, or in the middle of their rock steady boxing or physical therapy, they wear off. So they get that rescue medicine and then they use the Rytary, the longer acting to have. So think of it like a migraine patient who has a prophylactic medicine that they take every day, but when they get a headache, they take an abortive medicine like Ubrelvy or something like that. So we do the same thing with our Parkinson's patients. You have your standard, medicine throughout the day, and then when you have breakthrough off periods, then you have a rescue medicine that bridges the gap from one dose to the next.
Now, speaking of different formulations of levodopa, what about this so-called natural form of or source of levodopa called mucuna pruriens?
So mucuna has levodopa in it, but remember that we talked about those two enzymes in the periphery that chew up the levodopa? The mucuna doesn't have any carbidopa in it. So it's not a very efficient way to deliver levodopa, because most of that levodopa is going to be chewed up in the periphery by those two enzymes. So it's a much more efficient delivery to give you as a tablet that already has carbidopa in it, and then if we need to add a COMT inhibitor, so you don't basically have to take a wheelbarrow of mucuna to get what you get out of 1 or 2 tablets of cinnamon.
Yeah, so therefore, is nausea therefore more common in your patients that take mucuna pruriens?
Yes, so nausea is more common because we don't have that carbidopa blocking dopa decarboxylase. So a lot of that levodopa is turning into dopamine in the periphery, not crossing the blood-brain barrier, causing nausea, vomiting, and orthostasis, or low blood pressure, which causes the dizziness.
And of course, it's pretty expensive, right? It's not really covered by their insurance, is it?
No, it's over the counter.
Yeah.
So you'll find that most supplements are, one, not FDA approved, or they don't look at them, so you don't really know like how much mucuna am I actually getting in that pill, and is it all mucuna? And yet it's not covered by your Part D.
Yeah, and then one patient of mine says, I'd like to invest my money on this mucuna because I think it will not lead to dyskinesias and motor fluctuations down the road. What are your thoughts about that?
Yes, it's not the levodopa that causes the dyskinesia. So remember that those patients in Ghana who had never had exposure to levodopa, but got levodopa year 6, 7, and 8, so into their disease progression as that therapeutic window was getting narrow, they developed dyskinesia right away. So it wasn't their exposure of 5 or 6 years of being on levodopa. It has to do with that therapeutic window that gets narrow, so that you then peak above your therapeutic window and you have on time with dyskinesia, and then you trough below the therapeutic window and you have off periods with tremor and rigidity. So the dyskinesia is a function of the disease progression. It's not a function of levodopa exposure. What levodopa does is it pushes you above your peak, your therapeutic window, and therefore you have on time with dyskinetic or involuntary movement.
Yeah, you know, there's another natural source of L-Dopa. Or dopamine, which is fava beans. You know, have you guys used fava beans for cooking or in your kitchen or in your cuisine? Fava beans, but it's a lot of beans though. So, for instance, if I remember this right, a 250 milligram, or should I say, 100 milligram tablet of carbidopa levodopa, which is 100 milligrams of levodopa, you will need about half a cup of fava beans. So if you take 2 tablets of levodopa, you need 4 cups, and you take this 3 times a day, you need 4 cups of fava beans for breakfast, 4 cups of fava beans for lunch, and 4 cups for dinner. And guess what fava beans causes, right? It makes you very gassy. It makes you very gassy. So I tell my patients, if you're going to take your fava beans today, don't come to my office, okay? Just take your carbidopa levodopa when you come to my office. But I do have some patients that you know, are really insistent on the so-called natural sources of dopamine. Now, I've had also patients that talk about tyrosine and phenylalanine. You know, they go to their naturopath doctor and say, oh, these are natural sources, precursors of dopamine, and maybe we should manage you with this first before we go to the synthetic carbidopa, levodopa, and Rytary. So are you impressed with the benefits of these so-called supplements, tyrosine and phenylalanine, and so-called natural sources or precursors of dopamine?
No, and I think that I would spend more of my money on exercise so that there is more data to support exercise and of that aerobic exercise in improving your Parkinson's symptoms and maybe slowing it down than all of these other precursors and other sort of fancy chemistry. And so exercise, remember that your levodopa, it only helps the motor symptoms of PD, tremor, rigidity, bradykinesia, that slowness of movement and trouble with gait and balance. It makes non-motor symptoms of PD worse. It makes you orthostatic or have low blood pressure, which leads to dizziness and falls. It can cause confusion or hallucinations. It can cause impulse control disorder. And so our job is to try to get that balance just right, that you have enough meds on board that you're mobile, but not so much that you're fainting every time you're standing up or that you're hallucinating. And we know that exercise helps not only motor symptoms like tremor and rigidity and stiffness and gait, but it helps non-motor symptoms. So it helps your constipation. It helps you sleep better. It helps your cognition. And we think maybe aerobic exercise makes those neurons that are making dopamine but dying off, it makes them make new connections. The more connected they are, the more robust and healthy they are, the slower they die off, the slower the progression of the disease. So we want aerobic exercise to keep the brain young and healthy, and then we want resistance training to keep the muscles and the bones strong and healthy. So remember, you have bradykinesia or slowness of movement. Just as the reason you're not swinging your arm, it's nothing wrong with the muscle, it's just that getting the slow message from the brain. So we want resistance training to make that muscle strong and healthy, especially your quadriceps that get you in and out of a chair, in and out of the car, in and out of bed. And then when the muscles, when they push and pull on the bone, that's what tells the bone, hey, I need to absorb the calcium in your diet or in your supplement and deposit it in the bone. So if the muscles aren't pushing and pulling on the bone, then you just get more osteopenia or osteoporosis. Even if you're just sitting there taking your calcium supplement, you're just excreting it in the urine, having expensive urine. So we want both resistance training for muscles and bone, and then aerobic exercise for the brain. And I think spending your money there is much better spent than all of these other supplements of tyrosine and all of that stuff.
Now, going back to that discussion on supplements, one of the things that my patients very commonly, come to my office saying, I take this and that. One of the more common supplements they take is glutathione. So, can you enlighten us on your experience on glutathione for Parkinson's?
Yeah, so the studies in glutathione were done in a test tube. So yeah, the chemistry works, but guess what? Glutathione doesn't cross the blood-brain barrier. So even if you get it as IV, or some people actually get it into the spinal fluid, it's not crossing the blood-brain barrier. So the chemistry works, but in the test tube. So I wouldn't spend my money on glutathione, although it's all over the internet.
Yeah, absolutely. Having said that, there have been studies of both IV glutathione and intranasal glutathione for Parkinson's, and there seems to be a mild symptomatic effect, and we really don't understand how that is, but it probably modulates the way that the body or the brain uses dopamine. The thing about those studies, though, is that in all those studies that use placebo in comparison to glutathione, there was a very strong placebo effect. In other words, glutathione was working just as well as placebo. So the question is this a placebo effect or not? And mind you, am I right to say that in Parkinson's, the placebo effect is pretty strong?
Yeah, it's huge. So the placebo effect is huge in Parkinson's disease because remember, Parkinson's is the poster child for the mind-body connection. So everything that you're thinking, feeling gets reflected in the Parkinson's disease. If I put a white coat on and give you a little pill and tell you it's going to help your tremor, you're going to go home and have less tremor. So we have to figure out how to harness that placebo response because it works, especially in Parkinson's disease. And it's one of the reasons why it's hard to get drugs to get FDA approved, because in the phase 3 trials, especially these disease-modifying agents, they are not any better than placebo because the placebo response is huge.
Yeah, absolutely. And I'm also impressed when we do drug studies for Parkinson's. You and I have participated in multiple studies since our fellowship days. But I'm also impressed with how patients on placebo get the same side effects as patients that take the real drug. It makes you wonder, it's both positive and negative, I guess, huh?
Right, that's true.
That you get both the positive benefit as well as the potential side effect. And ergo, the importance of, a double-blind placebo-controlled study to really show that, this new drug for Parkinson's is head and shoulders really superior to placebo, and that the side effects are acceptable and just a little bit more than placebo, and nothing, really big. Now, one of my difficulties in when I see patients with long-standing tremor, that's so-called either Parkinson's tremor or essential tremor. Those are the two most common tremor patients we see in our clinic, right? So those patients of ours that have very long-standing tremor and they were diagnosed with essential tremor, do you sometimes see some of these patients convert to Parkinson's?
Yes. So, and it's not unusual for an essential tremor patient who's had a tremor 20, 30 years to have some resting component of that tremor and maybe even a little bit of rigidity. And so that's where we would do a DAT scan to confirm that, yes, this Parkinsonism, that resting component of the tremor, is just all part of ET, essential tremor, and it hasn't converted to Parkinson's disease. Although it's not unusual that a patient has had ET for 20, 30 years, and then in their 60s, 70s develop Parkinson's disease.
So it's possible to have more than one disease in the brain, yes, right? More than one movement disorder. And in fact, the biggest neuropathology study for essential tremor, which was published a few years ago, showed that patients with essential tremor may have Parkinson's disease. Those of you that have a little bit of Parkinsonism, I should say, may have Parkinson's disease, may have multiple system atrophy, may have progressive supranuclear palsy. So it's not just ET, but when you get older and develop some Parkinsonism, you could have developed, another neurodegenerative disorder, the most common of which is Parkinson's. So if an essential tremor patient develop Parkinson's disease or one of these atypical Parkinsonian syndromes, will you manage them differently?
Well, it depends which Parkinson's syndrome they develop. So if it's MSA or PSP, DBS is not going to be an option for that tremor. If it's Parkinson's disease, then we can manage the tremor with DBS or deep brain stimulation, and we can treat the rigidity and bradykinesia with levodopa in those patients. And then many times they're still on either a small dose of primidone or propranolol for the ET. And then it's important to sort of explain to the patient which tremor is which, because many times they're like, I'm taking my levodopa, but my tremor's still there. But, you know, it's the action tremor, it's the kinetic tremor, the tremor that I'm going to go pick up a glass or something and then I have that tremor. It's not the resting component of the tremor. And so then we have to sort of pick, you know, which DBS target we're going to use.
Speaking of tremor, I have some patients that are defiant when I make this initial diagnosis and dubious of my initial diagnosis of Parkinson's, because they say, I don't have a tremor. How would I possibly have Parkinson's at this point? So is there Parkinson's disease without tremor?
Yes. And so, in fact, half of PD patients never develop the classic resting tremor. So they're rigid predominant. They just have the rigidity and the bradykinesia, gait and balance issues, but they don't have the classic resting tremor. But those patients, if they insist on confirming the diagnosis, we can always help push them in that direction by doing a DAT scan or a skin biopsy for alpha-synuclein, and it would be positive.
And then for our own knowledge, is there a way to differentiate just from looking at the characteristics of the tremor? Is there a way for me to differentiate more or less, is this more essential tremor or is this more Parkinson's tremor? Is there a way to differentiate those two?
And so essential tremor is a bilateral tremor. Many times there's a family history of tremor that dad or mom, grandma, grandpa, they all had a tremor. They would shake when you had a newspaper. Although, gosh, you know, now the new people, they never read a newspaper that's on paper. I guess they would shake the iPad, and then they would have sort of a shaky tremor when they would hold a cup or utensils. So essential tremor is usually bilateral, and it's an action or kinetic tremor. I'm going to pick up something and bring it to my mouth, and I'm going to see the tremor. Mm-hmm. Parkinson's is a unilateral. It starts on one side of the body and then progresses to the other side. So the tremor starts on the hand or the foot or the chin, and it's a resting tremor. So it's kind of 3 to 6 hertz, and you can always predict. So many times, like, patients will say, well, how do I know if that's dyskinesia or the tremor? So the tremor is, you can predict the next movement. So I know that my tremor is going to go like this. If I'm dyskinetic, it's random and I can't predict the movement of the chin or the jaw or the hand. And so PD, it's resting. So you're watching TV and you see that hand kind of go like this, or the foot kind of taps, or you have a chin tremor. And it's unilateral and then progresses to the other side in 5 or 6 years.
Got it. Okay. And then what about patients? Once I make the diagnosis of Parkinson's, some patients tell me, or some patients ask me, especially their family members that are at risk for Parkinson's, whether there is a way to prevent Parkinson's in the future. Is there such a way to prevent it from coming out? If they are at risk, there's a family history.
Right, so there's no way to prevent it right now. And so many patients will say, well, if I have Parkinson's disease, what does that mean for my kids?
Right.
So we don't really know exactly what causes PD, but we know that there's some genetic component. So you have some genetic mutation that puts you at risk for some environmental toxin that turns that gene on. So an herbicide, a pesticide, things like TSE were dry cleaning fluids, that sort of thing. And so that you need both of those things together to get the disease. So just having the gene like LRRK2 or PINK1 doesn't mean that you're going to get the disease. And just having exposure to herbicides or pesticides doesn't mean that you're going to get the disease. That you need both of those things together to get the disease. And right now, we don't have anything that would stop or prevent or regress the symptoms. We certainly are trying to find them, and we're doing phase 2 clinical trials on disease-modifying agents, but none of them have made them past that placebo phase 3 trial.
Yeah, no, having said that, as we used to say that the pesticides were the number one, risk factor for developing Parkinson's, especially if you're at risk. And then down the road, there's other things that came out like head injuries and concussions and so on and so forth. And then even more recently, just pollution. And we're all screwed, right? Yeah. If it's pollution, we're all screwed. Unless you live, in a completely industrial-free, environment in the boondocks, I guess, right? But there was a study that, for instance, out of Mexico City, where they looked at the brains of different kinds of people that died prematurely. They didn't die of Parkinson, they died of something else. And since it's a very highly polluted city, they looked at their brains, different ages, from little infants to elderly, and what they found is that these brains of these patients that died of something else accumulated the so-called toxic proteins like alpha-synuclein for Parkinson's. They accumulated amyloid for Alzheimer's, tau for Alzheimer's, and some of these degenerative Parkinsonism/dementia syndromes, and so on and so forth. So really, it's very difficult for us to modify these other factors that we're all exposed to. But definitely concussions, we can prevent that, right? For instance, there's more concussion awareness nowadays.
So don't have your kids play football.
Right. And then don't spray pesticides. Don't live in a farm. Drinking well water is one of the risk factors as well.
Yeah, so we took lead out of the gasoline in cars, but not out of jet fuel. And so anybody who lives near an airport, that's all what that air pollution is has those particulates.
And then you mentioned PCE. There's so much press about PCE nowadays. If you check the ingredients in their house cleaners, check it out. The bathroom cleaners, the things you use for your oven, things you use for your floor, there's PCE there, trichloroethylene. Yeah, it's one of the risk factors now.
It's a degreaser.
Yeah. It's everybody uses this in shops, in your homes, and so on and so forth. So it's really very difficult not to get exposed to these so-called risk factors.
Because there was even a study, so even though you're not working in a dry cleaning place, but if you live in the same building where the dry cleaner's on the bottom and you share the same HVAC system, then you're exposed to TCE, so that you get the exposure.
Now, many of my patients who are very concerned about toxin exposure and heavy metal exposure and so on and so forth, and they get a panel of blood work and urine tests from their naturopath saying, oh yeah, your mercury level was this and your lead levels were astronomical and blah, blah, blah. Let's do chelation therapy.
Right.
Okay, so chelation therapy is supposed to take out these so-called heavy metals. So are you impressed with the so-called benefits from chelation therapy?
No, so 20 years ago, at Medicare, I'm sure they still do, paid for chelation, and so we would actually admit patients to the hospital and chelate them, but it didn't really make a big difference.
So really chelation works best when there is an acute exposure. Like for instance, believe it or not, many years ago, and this was back in Asia, in one country, there was I was consulted for a little kid that developed tremors like this, and the kid was like 13 or 14 years old, and I said, wow, is there a family history? No, there's absolutely nothing. And the only traceable risk factor was somebody broke a beaker of mercury during their chemistry class, right? And so the entire school, which was air conditioned, got exposed to mercury. And so there was suddenly a surge of young students that developed tremors, Parkinsonism, jerking, dystonia, all sorts of movement disorders, fuzzy-mindedness. So a lot of them, made it to chelation therapy and detoxification and all that.
Yeah, so I had a patient where, arc welding exposes you to manganese and mercury and these sort of things. So her office was above the welding sort of factory, and she never welded herself, but she was actually exposed to the fumes and all of that, and so she developed Parkinson's.
And thank you for mentioning that, because there's such a thing called welder's Parkinsonism, right? There's welder's Parkinsonism and welding as a risk factor for Parkinson's. Those are two different things. So among welders, for instance, there is an increased, incidence and frequency of Parkinson's down the road. But at the same time, if you're acutely exposed to high levels of manganese because you're a welder, you can develop acute or subacute, meaning within a few weeks, within a few months perhaps, of acute or subacute Parkinsonism. So manganese is one of those heavy metals we have to be concerned about. But mind you, is manganese only found among welders? I thought in some polluted environments, it's also found in water.
Yeah, lots of things are found in water. Lots of things that we wouldn't want to be found in water. So especially if you live in an agricultural area so I mean, that's why you see these pockets of Parkinson's disease, like, around the Imperial Valley in California, or, the Texas-Louisiana border, like Beaumont, where there's all of that oil refinery, or in the Midwest in Milwaukee, where there's all the paper mills. And so all of this exposure to all of these things that shouldn't be in your body, that get into the water, that get into the air, cause a higher incidence.
I guess if you decide to run away from the pollution from the city and go to a rural place, make sure you don't live close to a mining community. That's number one. Otherwise, you'll be screwed, right?
Don't drink well water.
And don't drink well water, right? Absolutely. Yeah, did you have a question? Yeah. And then, many years ago, and this is probably true in some of the old cities, the pipes for the plumbing in very old cities had lead. And so those were converted, I forget now whether it was in the 1970s or 1980s where these were converted to non-lead pipes. So there was quite a high frequency of Parkinson's and degenerative disorders in those cities where they had lead pipes for plumbing. Yes. There you go. Yeah.
Can you repeat the question when somebody asked, please?
Oh, yeah. No, he was just mentioning that in Michigan, right? Yeah, that there was this concern about lead pipes for plumbing, and that can lead to neurodegenerative disorders, including Parkinson's disease. So going back to Parkinson's now, because we got a little bit sidelined there. But okay, for patients with more advanced disease, let's say motor fluctuations. Now, how do you choose now, especially now that we're practically in the cusp of having the approval of this subcutaneous pumps of either levodopa or apomorphine? How do we choose now which intervention our patients will undergo?
So always we want to choose the therapy that works like the normal brain. The normal brain gives you continuous infusion of dopamine over the 24-hour period. It doesn't pulse you with dopamine every 3 or 4 hours. So, we would start with long-acting levodopa, and then I always think your 5th dose of levodopa should be a pump. So as a clinician, I want to choose the less invasive reversible procedure first, although when I give patients the option of we can do DBS or Duopa or pump, 9 times out of 10 they choose DBS first, whereas a clinician you would choose the reversible, less invasive therapy first. But I think they are choosing DBS because DBS has been around for 20 years, they know people in their support group who've had DBS, they don't know anybody on Duopa, and it has this PEG J, this tube hanging out of the tummy, and who wants that? But this year, we're going to get 3 new subcutaneous pumps if they all get approved. So it'll be a much easier therapy to jump on board, and if you don't like it, to take it off. And so I think that we start with oral medicines because that's super easy to take. There's no skin reaction. But your 5th dose, 5 doses of levodopa means that you're peaking and troughing 5 times a day, that you're having those motor fluctuations 5 times a day. And what causes the disability in Parkinson's disease are the motor fluctuations, and of those, mostly the off periods, the troughs, although the peaks with the dyskinetic movements can be also socially embarrassing to patients, can be exhausting. And so our job is to keep you in that therapeutic window as much as possible through the 24-hour period, and the easiest way to do that is using a pump. So I think when the subcutaneous pumps come out, we're going to be using it a lot in those patients, and if you tolerate it, we're going to keep it, and if you don't, I think many of those patients are actually going to go back to Duopa and say, once you're on 24 hours a day, you're not going to go to 6 doses of Cinemed and be off 6 times a day, especially because once you're on, you forgot how much off periods you were actually having on your oral medications, that every time you ate something or you forgot your dose or you were late with your dose, then you fell into that trough, and once you're in that trough, you can't really do anything. And once you start to plan your day around every single dose of levodopa, then you stop doing stuff. And then your world gets, more, it shrinks, and not only does it for you, but also for the caregiver and the rest of the family. So we should think of the pumps as a way to liberate yourself from Parkinson's disease and continue to do everything that you want to do without having to plan ahead every 3 or 4 hours.
Yeah, I just want to circle back to what you said earlier on about the continuous stimulation of the dopamine receptor. So is there an advantage to stimulating the dopamine receptors in your brain in a tonic, continuous fashion versus, pulse it with the medicine that you take by mouth and it kind of peaks and then it troughs, it goes up and down, so it's so-called pulsatility of stimulating your brain receptors versus this infusion therapies which will give you, a very tonic, continuous stimulation of the dopamine receptor. Is there a difference? Is there an advantage for one person?
I think so, because I think this room shows it. So the fact that this room, if we compared it to a room 20 years ago when we only had Sinemet and amantadine and very few options, and most patients were taking Sinemet every 2 or 3 hours. So they were pulsing. Today, we have patients on once-a-day medicines, long-acting forms of medicine. So you're on dopamine agonist, you're on Levodopa with multiple adjuncts. So you have more continuous dopamine tone. Nobody's dyskinetic in this room. And
so far.
So far, right. And they're all on their best on. And so using a pump to keep that continuous dopamine tone where we want it to be, we won't need as many adjuncts with the pump. Because we don't need a COMT inhibitor. Well, it depends which pump we use. But, we won't need all of it because you're not peaking and troughing so many times. So we need less medicines to keep you in that therapeutic window. So the reason that we're using 2 or 3 or sometimes 4 PD medicines at the same time is that we're trying to keep you in that therapeutic window as long as possible before you wear off. And on a pump, there is some wearing off. You still notice some troughs when you eat and that sort of thing, or when you do exercise, but the trough is not that deep, and so it's much easier to get out of the trough in a pump. So let's talk about the different kinds of offs and how a pump helps you manage all of those offs. So the most common off is end of dose wearing off. It's the reason why your doctor goes from 3 doses a day to 4 doses a day, or from 1 pill a day to 1 pill 4 times a day to 2 pills 4 times a day, is the end of dose wearing off, that it doesn't last as long. My pill used to last 4 hours and now it only lasts 3 hours. So you add another dose. End of dose wearing off. If you're on a pump, it's continuous. It's on all of the time. I don't have to add another dose because you're always on. Then the other off is morning off. I'm taking medicines throughout the day, and then I go to sleep and I don't take any medicine. I wake up off. The trough is quite deep, and it takes a long time for that first dose to get back to the on position. So if I'm on a pump, so right now the pump is only approved for 16 hours Duopa, so I use a morning dose to get you on in 20 minutes and then continues on. The other pumps that will be approved this year will be 24-hour pumps, and we're going to run them 24 hours so that you don't have the morning off. You wake up on. It doesn't take 2 hours to get dressed and shaved and all of that sort of thing. So morning off, that's how we treat that with a pump. Then there's delayed on. Remember, we're taking pills in a gut that doesn't work in Parkinson's disease. You're constipated and you have gastroparesis. So that pill could sit in the stomach 30 minutes or 2 hours. As long as it's in the stomach, it might as well be on your kitchen counter. It's not doing anything until it gets into the small intestine. So if I use a pump, so Duopa today has, the reason it has the PEG-J is because we're going right into the jejunum to be absorbed where it needs to be and bypass that gut that doesn't work. So it doesn't matter if you're constipated, haven't had a bowel movement, had a chicken sandwich, doesn't matter, Levodopa's first in line. The subcutaneous pumps, we're going to bypass the gut altogether. So we don't care what's going on in the gut, when your last bowel movement was. We're bypassing the gut. So that takes care of the delayed on. And then there's the unpredictable off. That remember that your Levodopa, it's like gas in the car. So if you drive your car at 80 miles an hour, it's going to use up more gas than if you drive at 50 miles an hour. And that's why you notice that your pills last sometimes 3 hours and sometimes 4 hours. Every day is unpredictable depending on what you're doing. And it's not only physical exercise that burns through that Levodopa, it's also emotional stress. So you're paying your taxes, your kid's getting a divorce, your dog is at the vet and that sort of thing. All of that burns through your Levodopa faster than if you're just sitting at home watching TV. So unpredictable off, the pumps have an extra dose button already built in. So if I ate something that has lots of protein, I can add an extra dose. If I went to Rocksteady Boxing and I ran out of gas, I can add an extra dose. And then remember, those troughs are not as deep, so as I add my extra dose, it's much faster to get back into the on position. So that's why a pump is a much better way to manage your off periods than taking one more dose of levodopa, because that dose of levodopa could sit in the stomach for a longer period of time.
So what I'm hearing is that these pumps would be more for more advanced Parkinson's patients with wearing off, right? But they're not going to be for patients in the early stages of Parkinson's.
Well, it depends what you call early stages or what you call advanced stages. Mm-hmm. So I would say, why do we have Parkinson's? Why do we have to put up with Parkinson's and motor fluctuations? Why can't my fifth dose of my levodopa be a pump? So I have the disease for 5 or 6 years. I'm doing really well in that honeymoon period. Why not keep that honeymoon period going on with a pump? Why should I be taking 6, 7, 8 doses of levodopa and then decide to go on a pump? I would say use the pump earlier and make that honeymoon period last a lot longer.
And that's probably where the direction of research will be going, right? Because I think when these pumps are introduced in the near future, hopefully this year, right? One or both pumps will come out. They will be indicated more for patients that are wearing off, for more advanced disease. But I hear it loud and clear. I think that the needle should be pushed earlier and earlier, and that maybe we should not wait till later. And in fact, what if...
the same thing happened with DBS.
Right.
So we used to do DBS year 10. We had tried everything. There was nothing else to do. Oh, let's do DBS 20 years ago. And then gradually we started to do DBS earlier and earlier, year 5 and 6 or earlier. So that why does somebody have to put up with a tremor for 10 years? No, let's do DBS and dial out the tremor. Oh, you're dyskinetic? Why do you have to have dyskinesia 5 years before we decide to do DBS? So we push DBS from year 10 to year 5. The same thing is going to happen with the pumps. But we learned with DBS, so why make the same mistake again? Why not just start pumps at year 5 and keep you in that honeymoon period for a much longer period of time?
It makes you wonder also whether at some point we should be introducing this continuous, infusion therapies or introduction or stimulation of the dopamine receptors in the beginning. Well, instead of pulsing the brain and the pulsatility leads to motor fluctuations and dyskinesias, maybe why don't we just do continuous, stimulation from the beginning?
Well, we do that with type 1 diabetics. We don't have them on sliding scale insulin. They're on long-acting insulin in a pump. Mm-hmm. So there's not a single type 1 diabetic who's on sliding scale insulin today.
Yes, I won't be surprised if in the future we'll say, why don't we just do deep brain stimulation the moment I diagnose you with Parkinson's and forget about the medicines and the complications from medications. Or the flip side, why don't we just, instead of me giving you 3 times a day carbidopa, levodopa, we're going to pulse your brain for a few years with these ups and downs, and the pulsatility can lead to motor fluctuations down the road. Why don't we just do the pump from the get-go and just continuously, tonically stimulate your brain with dopamine? But what is the physiologic state though? With the dopamine that we produce in our brains, are our brains being pulsed with dopamine in the physiologic state? Are they being tonically continuously stimulated?
I think it's tonically continuously stimulated.
Absolutely. So when you tonically continuously stimulate the dopamine receptors, it mimics what is physiologic. And so when we give you the medicines by mouth, that's not physiologic. It's better than nothing, but it's not in any shape or form close to what your brain is supposed to be doing and what God designed it to be, right? For the machine to work, perfectly.
And we always want to make sure that the benefits of the therapy or medicine outweigh the side effects. So between DBS and a pump, a subcutaneous pump, the subcutaneous pump is much less invasive. We're not putting anything into the brain. It's not brain surgery, and we're not putting you at risk for some kind of infection there. And it's much easier to reverse if we don't like it for whatever reason.
Absolutely. So whereas DBS is invasive, the pumps are not, right? You can literally this is literally just a little, little gadget with, it's got a little fluid there. You kind of wear it in a fanny bag maybe, or tuck it inside your pocket. And it's got a little tube, and a little tube is attached, a little sticker, and that sticker has a little needle in the center. And it just introduces in a very continuous fashion under your skin, subcutaneous, the medicine that's being introduced, which in this case is going to be apomorphine or levodopa. And then at the end of the day, just take it out, and then the following day, just put it on again in different places. You're going to change, the areas where you put it, right?
Right.
That's the general idea. So I guess I guess can you combine deep brain stimulation with these therapies when this come out?
Yeah, so in fact, my best patients are both DBS and Duopa patients. Remember, the brain talks to itself in two ways. One is chemically, so that's what the medicine is the dopamine. And the other one is electrically, and that's what DBS does. So it's an electrical tonic stimulation of the brain. And so our patients that have, and it's continuous. So remember, we want continuous 24-hour therapy for PD patients because you don't go to sleep and the PD goes away. It's still there. And so we want to treat the Parkinson's disease when you're awake and when you're asleep. And so I have about half of my pump patients also have DBS on board at the same time, and they do really, really well. And one of the other pluses is that then we can get rid of a lot of these adjunct medicines and a lot of the side effects of those adjunct medicines. So less hallucinations, less orthostasis, less leg edema or swelling in the legs, and we just have you on 2 therapies, both of which are covered by Medicare A and B, so there's no Part D that we have to figure out how we're going to pay for and which foundation has money. So that's nice for us too, that we have 2 therapies that we don't have to worry about getting funding for Medicare patients.
So really the future looks like we're going away from the pulsatile therapies, right? And going more towards a direction of continuous stimulation of the dopamine receptors in the brain.
So I think the future of PD is going to be pumps and DBS and some kind of modification of your microbiome.
There you go. Okay, what about dopamine agonist? So you mentioned that one of the pumps that's coming out is apomorphine. That's a dopamine agonist, right? So what's the difference between a dopamine agonist and dopamine, which is levodopa?
So the levodopa turns into dopamine in the brain, exactly the same chemical that's missing in the brain, so it works like it should. A dopamine agonist, and the problem in the past was that we had only Cinnamate, a 90-minute form of levodopa, so it was pulsatile. So you're taking levodopa multiple times a day. Then the dopamine agonists came on board, and they go and they sit on the same receptors as dopamine, but they're not the same chemical. But they cause some side effects. So the dopamine, it's not a very clean drug, the dopamine agonist, so they go and they hit multiple dopamine receptors, D1, D2, D3, and so that not only do we get improvement of tremor and rigidity, but we got side effects like confusion, hallucinations, impulse control disorder, and excessive daytime sleepiness. But the pluses were that you could take it 3 times a day, or you could take the ER-XL version and only take it once a day, so that we like that because we're covering you not only during the day but at night. And then in the future, or medicines like apomorphine, they're D1, D5, so much cleaner drugs. There's no D3, so there's less impulse control disorder, less hallucinations. So in fact, when we look at the studies, the apomorphine subcutaneous pump actually had less hallucinations in the study than the levodopa. Whereas everybody thinks, I'm going to be mainlining Mirapex. That's not what apomorphine is. It's a cleaner drug, and in the future, in 2025, we're going to have D1, D5 dopamine agonists that are oral medicines that come as a once-a-day pill. But we'll have apomorphine.
So is there a certain symptom of Parkinson's that they would say, I would choose a dopamine agonist for this symptom because it is superior to levodopa?
Well, I don't, how would you answer that?
I would say tremor.
Tremor? Yeah.
I kind of favor tremor.
That will be interesting. Like once we get both pumps on board, how do we choose one pump versus the other? And I think that will come down to the skin reactions. Which, pump is going to have the least skin reactions, the least infections, the least erythema granulomas, and better tolerated. The other minus of apomorphine is that we're still going to be on some levodopa, not as much as you were before. So we're not going to be able to go to monotherapy. Whereas with levodopa, we can go to monotherapy and usually get rid of everything, maybe except a little tiny dose of dopamine agonist if you have restless legs. But yes, if it's tremor predominant, but in those patients, I usually go to DBS. DBS treats the tremor.
Got it, yeah. Is there such a thing as the patient being too old for dopamine agonist? Do you have a cutoff for age? Because you mentioned hallucinations, confusion, worsening of dementia.
So I would say cutoff of milligrams. So I have some patients that are just on 2 milligrams or 4 milligrams of rotigotine or Nupro for restless legs. And I don't use much higher doses if you have confusion or mild cognitive impairment, because we know we're going to get into trouble with hallucinations.
And thank you for mentioning restless legs, because that's the second population where I would favor a dopamine agonist over carbidopa levodopa, because in fact we use carbidopa levodopa for restless legs, except that it leads to augmentation and rebound. What that means is it bites you from the behind after a few weeks or a few months or a few years. So the RLS becomes earlier during the day, then it kind of creeps up, not just the leg, it starts happening, in your arms as well. Then you may wake up with RLS instead of just this being, in the evenings. Whereas the dopamine agonists, especially the longer acting ones, the dopamine agonists, are quite effective for RLS, but at the same time, the chances of developing augmentation and rebound would be less. But
right. So in my Duopa patients where we've been able to get rid of all of the adjuncts, so you're just on Duopa, there's a small subset that are still on 2 to 4 milligrams of Nupro to treat the restless legs, that we just can't treat it with the Duopa. So we need a little bit of a dopamine agonist to get the job done there. Or if you have a tremor that we can't control with the levodopa, then they go to DBS for that tremor control or any dyskinetic movement.
now, currently, what formulations of apomorphine, because I'm excited about this subcutaneous pump that will come out in the future along with the subcutaneous pump for levodopa, but what are the current formulations of apomorphine, which is the most powerful dopamine agonist in the market?
Right. And so we used to have Kimobi, and that's sort of
It's a sublingual, right?
As a sublingual, but it's a cautionary tale for PD patients and movement disorders neurologists, that here are these drugs that finally made it to market, that made it through all phase 2 and phase 3 and were better than placebo. And then they came to the market and nobody used them, and so the pharmaceutical companies took them off the market. And that's not what we want to happen in Parkinson's disease. We want to have access to more and newer drugs and different variety of drugs, because if one apomorphine, one formulation of a dopamine agonist doesn't work for you, then we can have another option. So we used to have Kimobi, which was a sublingual form of apomorphine that you would take as an on-demand therapy or rescue medicine. We still have Apokin, which is, think of it as like an EpiPen with apomorphine that we use also as an on-demand or rescue medicine. And then we're going to have the apomorphine pump, which has actually been in Europe for 30 years.
Right.
So why are we only getting it now? It's just, this therapy has worked very successfully in Europe and Australia and New Zealand.
Wonderful, wonderful. Okay, so what about patients that you send for DBS? When is a patient too old for DBS?
So DBS, you've got a window for DBS. So if you have developed any dementia, mild cognitive impairment, you're not really going to be a good candidate for DBS. We don't want to stick 2 stimulators in there and make that dementia worse. So those patients would be excluded from DBS, so that's why you guys get neuropsych testing. And also any patients who have untreated depression, then we want to make sure that depression is treated with before we go ahead with DBS. And then good patients for DBS are patients who have a tremor. So if you have a tremor that we can't control with medications, then we know that we'll be able to dial it out with deep brain stimulation. A patient who is on time with dyskinesia, and by smoothing out your medicines, you're still dyskinetic, or every time you take a dose of levodopa, you have dyskinesia, then DBS is a very good option in controlling or dialing out that dyskinesia. Those are the 2 main things with DBS. And then what we find, that once you have DBS on board, that your medicines last longer. And if we do it early on, remember, we're not doing it year 10 where you're doing it year 5, we can actually decrease your amount of levodopa and other medications, and then maybe later on they creep up, but we can decrease the number of times that you're taking medicines and the milligrams, and therefore have less side effects with DBS.
Yes, go ahead, please.
What about age for DBS?
Age?
So it depends how good your 80-year-old is. So if your 80-year-old scores well on neuropsych and is a good surgical candidate, I don't know, how old is the oldest patient Dr. Ponce has done DBS on?
I've sent him the oldest one so far, about 83 or 84.
92.
Oh,
No, that's
okay.
essential tremor though, right? Right, we're talking about Parkinson's. Yeah, the oldest one I've sent so far, I think I sent him the oldest so far, 83, 84. Yeah. Absolutely, yeah,
Right.
yeah.
And so-
But again, these are very clean 80-year-olds, right?
Right.
Very clean. Not demented and they're not very sick.
Right, so that it's not your chronological age, it's your functional age. You know, are you a good 84-year-old or are you a demented 70-year-old? You know, it doesn't matter you're 70, you have dementia, you're not getting DBS.
In fact, I'm very impressed at at how good our elderly patients with Parkinson's look nowadays, in comparison to when I was a fellow not too long ago, you and I. But like for instance, I just saw a 90-year-old patient of mine with Parkinson's the other day. I keep saying, "Oh my God, you look so good, and you don't act your age. You walk better and move better than a regular 90-year-old without Parkinson's." It's really amazing. So age is just a number, right? I mean, patient had no dementia. Patient wasn't, having all these hallucinations or delusions or whatever. But at some point, I guess the DBS will be offered even in older individuals, even beyond what we're doing now, right?
Right, exactly.
And what about these infusion therapies? Whereas DBS might have a cutoff, so to speak, an artificial cutoff, you think these infusion therapies will have an age cutoff in the future?
No, it'll have a caregiver cutoff. So if you're demented but you have a caregiver who can manage the pump, then you're still a good pump patient. And so the other thing with DBS is that if we do it early,
Right.
and then 10 years later you develop dementia,
Right.
then actually that patient is better off because once you can't tolerate the medicines, we can still treat the tremor and rigidity with the DBS.
Agree 100%. And I always have this conversation with psychiatrists and neuropsychologists whenever I receive a report of, patient is close to dementia and the patient is fluctuating, has severe tremors and ups and downs and takes the medicine, Levodopa, 10 times a day. And I kind of say, okay, this patient inevitably will develop dementia in a year or two and will be completely screwed, right? Once the patient develops dementia, because now DBS won't be an option and now we're stuck with medicines forever. Versus do DBS now before the doors are completely closed. I might accelerate that dementia a little bit by a few months, maybe at most a year, but at the same time give the patient quality of life for the next, whatever number of years the patient will
Right,
survive.
because as we have to sort of get rid of all the adjunct medicines and you're just down to 300 to 400 milligrams of levodopa, that patient's going to be a lot more comfortable with less rigidity, less tremor on that very low dose of levodopa than if they didn't have DBS on board. So then they'd be totally frozen, much more uncomfortable, and still demented.
Speaking of freezing of gait, freezing of gait is one of the most difficult things to manage in Parkinson's disease. Do you have any recommendations or tricks?
So the tricks for freezing, so it depends, what kind of freezing of gaits that you have. And so we always want to treat the cause of the falls and that sort of thing. If you're having freezing and falling because you're orthostatic, we can improve that by adding salt to your food, making sure that you're not on multiple blood pressure medicines that you don't need anymore. If you're having start hesitation or like morning off, that we can treat those off periods so that you don't have that stuttering, festinating get early in the morning. But then even if you're on, some patients still have freezing of gait, especially in narrow spaces, crowded spaces, if it moves from like carpet to hardwood floors. And then we use sensory tricks, either using a metronome or many people, they get stuck in their laundry room. So you just, use your favorite YouTube, something that has a beat, and you just cha-cha outside of the laundry room. Or it will put a laser line on your walker or a metronome. To help you with those sensory tricks, to help you with the freezing of gait that happens even during on periods.
One nifty thing that we saw in the last seminar, there was one exhibitor from Switzerland that exhibited the Parkinson shoe. It's a Parkinson shoe. So you wear this, and whenever you freeze, it sends a vibration, in your foot, and kind of, makes you, take that step. It's called a vibrating shoe. Now there was a different form of this. We got a really good lecture like a year and a half ago from Dr. Peter Tass from Stanford. He talked about the vibrating glove. So vibration seems to be one of those things that they're exploring for freezing of gait. And Dr. Tass showed us very beautiful videos of patients that are frozen, and they, the medicines may or may not help their freezing. And yet, if you do the vibrating glove, they're able to kind of walk and unfreeze themselves. So this is something to look forward to in the future.
So back in the day, in the 1800s, when James Parkinson's was actually making the diagnosis of Parkinson's disease, carriage rides, the bumpy low carriage
Absolutely.
rides, the vibration treated the tremor and the Parkinson's symptoms.
Yeah, they found out in the past that if let's for instance, back then they used to take the train, right, or the carriage, and so this bumpy ride makes them vibrate. And these Parkinson's patients, by the time they reach their doctor an hour or several hours after, they're all vibrated and all that, they're better, right? They go, wow, you're better. So where's your Parkinson's, right? So the question is, does vibration actually help? So they actually came up with a vibrating chair.
Yeah,
Back then, I saw this in the archives of pictures of the vibrating chair. And did it work? No, it didn't work. So it's not just a general, let's make you vibrate all over. And in fact, a patient of mine just a few days ago came up, showed me this nifty thing he bought from the internet. It's a vibrating thing that he stands on, right? You kind of have to, it makes you vibrate and your entire body vibrates. And, well, if it works, I can't argue against good results, right? But if it works for you, well and good. But so far, they've been trying to explore and fine-tune that general vibration versus let's send the vibration to stimuli to the parts of the brain called the basal ganglia where it matters most and where it may help, Parkinson's. So don't be surprised if we, in the future, we complement deep brain stimulation with physical measures like a smartwatch that gets sense of vibration or impulse or a vibrating shoe, or there was even one that was developed in Korea. It's a vibrating disc. You put it right here in your chest. And it sends a vibration, and whenever you have a tremor or you're frozen, it sends out that impulse, and you kind of get better. So don't be surprised if in the future we talk about these other non-pharmacologic ways to manage your Parkinson's. And in fact, there's one ongoing. There's the non-invasive brainstem stimulation. There's an ongoing study from Sion Neurostimulation. I'm not sure whether you've seen these studies, but it involves wearing a headphone device, and it stimulates in a non-invasive way your brainstem, and it's supposed to help the non-motor symptoms for Parkinson's as well as the motor symptoms. So I won't be surprised if this gets FDA approved in the near future, but there's ongoing studies on this so-called non-invasive brainstem stimulation. I think we have a few more minutes before we wrap up. Any questions from the audience? Because so far we've been, yes, go ahead, please. Let's make her do the microphone, please.
There you go.
Hello?
Could you just talk a little bit about auditory hallucinations?
Okay, so what about hallucinations?
Tell me about them, because I have them. Auditory.
Okay, what is the significance of hallucinations in Parkinson's patients?
So patients, you can develop hallucinations from the disease itself and from the medication. So medicines like dopamine agonists, those are things like Mirapex or Pramipexole, Ropinirole, or Requip, or Nupro, or Ticotine. They can cause both visual, usually it starts as visual before the auditory, and some people can even smell stuff, even though they're not cooking. And usually it starts, you feel sort of a presence in the room, but you look and then there's nothing there. And then you kind of see little things that move around in the carpet, or if the carpet has a design, it kind of turns into 3D or develops something, so it's a good time to become an artist. But remember, it's because these are not clean drugs, and they're stimulating all of your dopamine receptors, not just, the motor receptors. And so that's why when we get cleaner drugs, like apomorphine and the new D1, D5 dopamine agonists, we're going to have less of those side effects. But even if you never took any Parkinson's medicines, and you never took levodopa, some subset of patients are going to develop hallucinations as part of the disease.
So usually it's more common in elderly patients with Parkinson's and those that have cognitive issues. And those that take dopamine agonists, so hallucinations are more common among patients that take dopamine agonists. Those that take amantadine, amantadine is usually used for tremors and dyskinesias, and those that take anticholinergic drugs. And of course, polypharmacy. Aside from the medicines for Parkinson's we give you, and you're taking a heart medicine, a medicine for your bladder, a medicine to put you to sleep, a medicine for your allergies, a medicine for your diabetes, and so on and so forth. And you add all of these things up, and then one of them is going to be the last straw that broke the camel's back, and that would be the Parkinson's medicine that I give you. Now, having said that, if you have hallucinations though from the get-go, and you're a little bit fuzzy-minded, that's a red flag because we say, oh, that's not typical of Parkinson's. So hallucinations are more common in more advanced elderly patients, especially those taking dopamine agonists and polypharmacy. And then we have very good medicines to use for hallucinations in Parkinson's. The most favored one nowadays is pimavanserin. So if you haven't gone to the booth for pimavanserin, outside, make sure you have hallucinations, ask them about this drug. It is the safest drug for hallucinations. The problem with most antipsychotic drugs we use for hallucinations, they worsen Parkinsonism, whereas pimavanserin does not because it's not a dopamine blocker. Okay? Okay, other questions? Otherwise, yes? Give her the microphone, please.
Welding and manganese in Parkinson's.
Manganese, yes.
Yeah, how long does it take, like, the OSHA to come up with the new standard for airflow for welders? Do they recognize you as experts saying there is a problem, and then, hey, we need to change our airflow requirements, that type of thing?
I'm pretty sure they've done some, yeah.
So I think that now OSHA requires that you do have good ventilation because there's something called the welder's pneumonia.
Right.
So that if you're welding in an enclosed place and it's not well ventilated, they develop something that looks very much like pneumonia, but it's due to all of those fumes. And they're required to wear, the N95 mask and that sort of thing. So I think that it is well known and recognized and mitigated by using those safety measures. Yeah, so but they must. I think they have. What's that?
Yeah, I forget what it is, but it filters more of this heavy metals like manganese. Yeah. Okay. Other questions?
I'm going to take one from the Zoom audience.
Sure.
What can one do to elevate FOG? Does that sound
The freezing of gait.
fog?
Oh, FOG,
okay.
freezing of
They put
gait.
it
Okay.
in
Oh, well, we talked about
capitals.
that, right? About we did mention. Oh, do the medicines or deep brain stimulation, do they help freezing of gait in your experience?
So DBS doesn't help freezing of gait, and the medicines per se don't. But the more on time we can give you, the less freezing you're gonna have, the less off time you're gonna have, and freezing of gait you're gonna have. But you can still have freezing of gait on an on period when you make a turn or you're in a narrow space or crowded space or going in and out of an elevator, escalator, that kind of stuff.
Right. So freezing of gait can occur either in the on state, in the off state, or any state. Okay, so the off state is freezing is easy. Give you more medicines or do deep brain stimulation and make you more on. The on freezing is very difficult to treat. And that's where the physical measures come in, the cues and the physical therapy and just being careful and getting some training.
All
Okay.
right. Do we have any more questions from the audience? Okay, I have one more from the Zoom audience. Can you speak on probiotics?
There you go. You talk about the leaky gut and yeah.
So the microbiome, if somebody came and looked at us and said we were a little tricorder, like what is this organism? We're only 10% of the cells are human cells. The rest are part of the microbiome. They're all bacterial cells, virus, or these little bugs called archaea. So it turns out that the microbiome is doing lots of stuff for us, and we didn't realize that. We thought, oh, bacteria, it's all bad, let's kill it off with antibiotics. But it turns out that our microbiome, it helps us digest food. And when you look at sort of the mother's milk for the baby, 80% of that is long-chain, oligosaccharides that the baby can't metabolize, can't digest. They're actually made for the bacteria in the microbiome. So the baby's only getting 20% of that milk, and the microbiome is getting 80% of that milk. So the microbiome must be doing something very important. So it makes things like vitamin K for us, vitamin A. It turns vitamin D from the inactive form to the active form. It makes things like serotonin, which helps us with anxiety and depression. So it helps us make lots of things. And we think that it's associated in Parkinson's disease in that we know that the microbiome of patients with PD is different from a patient without PD. And within the PD population, that a tremor predominant PD microbiome is actually different from a rigid predominant microbiome, so that there's even difference there. And so they did studies, I don't remember now if it was UCLA or USC, where they were taking mice that had a LARC2 mutation but had no bacteria of their own, and then they were introduced from a microbiome of a Parkinson's patient, and they became Parkinsonian. They developed a little tremor, a little bit of rigidity, then they wiped out that microbiome with antibiotics, and they got better. So we know that the microbiome has something to do with Parkinson's disease. And we think maybe, and we want to, and we don't know exactly who the good guys are and who the bad guys are. And so the question was about probiotics. You know, we want to feed the microbiome prebiotics. What does it want to eat? It wants to eat fiber. And that fiber feeds the good microbiome, the good bugs, so that they can crowd out the bad bugs. Because the bad bugs can produce, like if there's a lot of E. coli and that sort of thing, a thing called curlin. It's like a protein that sort of spiraled, and it looks like alpha-synuclein, and so that it sort of templates and misfolds the alpha-synuclein. So remember, we have normal alpha-synuclein, but if it's misfolded, then it acts like a prion and sort of marches up your vagus nerve and goes from the gut to the brain and causes the Parkinson's disease. And we don't want that misfolded alpha-synuclein to do its bad job in the cell. That's what the Lewy body is. It's full of this misfolded alpha-synuclein that can't be taken out or cleared out of the cell. So what we tell patients is that you want prebiotics. You want lots of fiber, because think of the probiotics. Think of a field. If you don't till it and get it ready to put the seeds in and to put the fertilizer, like nothing is going to grow. Even if I throw the seeds in there, it's not going to grow. The same thing with the probiotics. We want to make sure that that gut is ready, to make sure that when we give it the probiotics, the good bacteria, that it has a place to grow. So first we want prebiotics, lots of fruits and fiber and lots of fiber. So it makes the good bacteria grow longer, grow better, and pushes out the bad bacteria. And then the leaky gut is that if we just feel it's, lots of donuts and cupcakes and that sort of thing and no fiber, then the bacteria says, what I eat is small chain fatty acids, which it finds in the mucosal lining of the gut, and it eats that because it's not getting the fiber it wants. And then that's what causes the leaky gut, where you then get this misfolded alpha-synuclein that makes it from the outside into the inside of the body.